Welcome everybody, and thank you for joining today's webinar on restrictive practices during COVID-19. I'm Amar. I'm a forensic psychiatrist at East London Foundation Trust, and I'm the National Improvement Lead for Mental Health Safety with the Mental Health Safety Improvement Programme, which is part of the National Collaborating Centre for Mental Health at the Royal College. Over the last couple of years, we've been running the first ever National Quality Improvement Programme to reduce the use of restrictive practices across mental health wards in England, working with about 25 different trusts and 38 wards across the country to see how we can together come up with ideas that can reduce the use of seclusion, restraint and rapid tranquilization. And as this programme has been coming to a close this year, COVID-19 hit. And during the last couple of months, we've been really interested to learn from the teams across the country about how they've been trying to reduce and maintain as little use of restrictive practices as possible. Of course, we all know that the population we look after are one of the most vulnerable in society. And so making sure that we are really attuned to the possible restrictions and liberty during COVID-19. Obviously, all of us in society are exposed to some restrictions to our movements right now, but those who are detained in hospital under the Mental Health Act have potentially there's a real need to make sure that they are exposed to the least possible restrictions and liberty at the moment. So I'm looking forward to hearing from the three teams who are going to be presenting this afternoon about what they've been testing and learning about how to use restrictive practices as little as possible during their wards. So I'm going to hand over to Emily now to talk us through the plan for the next hour.
Thank you, Amar. So just a couple of housekeeping things. So we welcome questions for our speakers. And if you'd like to ask a question, you can use the Q&A box on the right-hand side to ask a question. You can also give a thumbs up to a question that someone else has asked, and then we know that that's one of particular interest to you. We will hear from all of our speakers, and then we'll do a Q&A at the end. So please do keep your questions coming in throughout. This webinar is also being recorded, and we'll share a link afterwards. So please share with your colleagues or anyone else that you think it might be helpful for. So let's get started. So this webinar marks the launch of our COVID-19 change package on how mental health wards can prevent a rise in the use of restrictive practice. And Amar's just explained sort of all the reasons why this area is so important at the moment. And we've seen a huge number of changes, adaptations, new ways of working that have happened as a response to the pandemic. And we've collated all of this knowledge, so everything that's been shared on Twitter. We also reached out to the wards that we've been coaching in the Mental Health Safety Improvement Collaboratives to ask how they've prevented restrictive practices from increasing. So we've taken all of this input and our knowledge from previous work on this area to make this change package. And it firstly consists of the driver diagram that you can see on the screen, which lays out our theory based on everyone's input. And what follows after the driver diagram and the change package are examples of all the change ideas that you can see listed on the right-hand side. And for each idea, the contributor has said what they were trying to solve, what they did, what their learning was, and any advice for someone who might want to try out that idea. And we're really grateful to everyone that contributed and took the time to speak with us to create this really rich resource. You can access the change package on our website, and it's also been shared very widely on Twitter. So today we're going to hear from some of the contributors to that change package, who will each talk about one of the primary drivers on the left-hand side. So we've got engagement, communication and well-being being the big sort of overarching umbrella topics in how we can prevent a rise in reducing restrictive practice at the moment. And then these are broken down into the smaller secondary drivers and then the more tangible change ideas on the right-hand side. So first of all, in relation to engagement, we're going to hear from Lauren and Lily, who are from Keats ward in Greater Manchester Mental Health Trust, and they'll be talking about how they've been engaging patients during COVID-19. We'll then hear from Danielle and Beth, who will be giving their perspective from learning disability secure settings and how they've been communicating well with everyone on the ward to prevent a rise in restrictive practices. And then we'll hear from Steve from East and North Hertfordshire, who will share how their How Are You Doing team have been supporting staff and generating supportive discussions within their trust. So we'll get started, and I'll hand over to Lauren and Lily, who'll be talking about the first topic of engagement.
Hi, my name's Lauren. I'm a Deputy Ward Manager on Keats Ward.
Hi, my name's Lily. I'm also a Deputy Ward Manager on Keats.
Keats Ward is a 22-bedded female acute ward in Greater Manchester. So today we want to talk about some of the activities that we put in place since the pandemic, and the aim for that was to reduce the need for maladaptive coping skills and to then reduce the need for restrictive practices. So what we initially noticed was there was quite a big change in the ward routine. So for example, all of our new patients that were coming in, they were needing to isolate in the bedroom, and then they'd need to be swabbed and then stay in the room until their result was back. There was also changes with the staff needing to wear masks, and then also with people that had leave, we did need to keep advising people about using that as least as possible with the current guidelines. We also noticed that a lot of our patients had quite a change in their usual daily routine. So for example, not being able to see their family and friends as often as they would, or have face-to-face contact, not being able to carry out hobbies or their usual coping skills, for example, exercising, going to the gym, swimming and things like that. And then that led to an increase in their anxiety, and then the need for hospital admission. So the first thing that we wanted to look at was communication and how we could communicate the most recent and up-to-date guidelines in a condensed way to not overwhelm and distress people. So Lily's going to speak a little bit more about the groups that we put in place about communication.
And yes, so as Lauren said, we've wanted to come up with new innovative ways in which we can share the information with our patients. In doing so, we want to make that, we want to deliver it in a clear and easy way in which they can understand that. As the guidelines are changing quite often, it can be quite confusing for the patients to understand that, as it can include medical jargon. So we want to try and decrease that and deliver it in an easy format. So the first way in which we did that was in a booklet. This was a visual aid for them, and it included information on COVID. So we took the booklet to the community meetings, and this was discussed with them there. So the patients can then keep these booklets with them as a prompt, and they can refer back to these. And then obviously if they had any questions, they could bring it back to us and we could discuss it further with them there. In the booklet, it had a visual guide as to the hand washing technique, because we now are encouraging all patients to wash their hands when entering the ward, when leaving the ward, and also when before and after engaging in any activities. So we want to ensure that they are using the correct technique. It also included information on the 2 metre social distancing rule, and also on limiting their leave and things like that. The next the way in which we delivered information was a more interactive technique. It was a dice game, so it was quite simple. We rolled the dice, and on each face of the dice it had a question. So the question might be show me the 2 metre rule, or explain to me the symptoms of COVID. We found that with the game being a bit more interactive, the patients were able to retain the information more, and they were also learning from each other. And obviously, because it was more interactive, they found that we had a bit more, the level of engagement was a little bit better as well. Another way that we've been delivering information on the ward was through our newsletter. So it's done 2 weekly, and we've been doing this for quite some time on Keats now. It's called the Keats Chronicle. This has been implemented on Keats for quite some time, but we've just been able to adapt it a little bit to suit COVID. So it's done by one of our patients, and she puts the information together with the support of staff, because obviously with it having information to do with COVID, we want to make sure that it is up to date and it is correct. So like I say, she puts that together, and then this too is also delivered within the community meeting. As it's done by another patient, we found that the other ladies on the ward do receive that quite well. It's discussed then together, and they then have an input, and they can put their views forward, and that's then put into the next one as well. So the reason that we've been doing this, we want to try and get it in as many different formats as possible and hope that one of the patients or all of the patients will be able to receive that and hopefully learn, and that will suit one of the formats will be able to suit them in hopes to be able to reduce their distress and anxiety around this.
So what we found with the groups that we've done around information sharing was that the more interactive it was, the more patients wanted to engage. So we wanted to take that further to support people with their coping skills and also reduced the need for restrictive practices. So what we wanted to do was a lot of different groups to interact with different people. So some of the groups that we've done was the weekly planner groups, coping wheels, fortune tellers, positive post-it notes, laughing yoga, postcards to loved ones, the Zoom quiz that we do weekly, compassionate colouring, weekly self-care checklist, isolation packs, and the gardening group. And the gardening group was actually requested by the patients as this was some of their hobbies at home, so we wanted to continue this on the ward. So we're going to speak a little bit more about two of the groups that we've done. So Lily's going to speak about the coping wheels.
Yeah, so like Lauren said, I did the coping wheels. This was an idea that we had to do after the community meeting. So obviously delivering this information we found was a little bit distressing to some of the patients, or a little bit overwhelming, as they found that their routine might be changing, whether that be on the ward or post-discharge. So we want to try and highlight some of the positive skills that they already have, or they can share the skills with each other. So it was quite a simple task, but also creative and something that they could get involved with. The template that we used is now on the improvement network. So for anybody that wants to create this in their own area, you are now able to do that and download that online. So it's, as you can see, it's quite simple, just two circles, one on top of the other, and the top one having a cut-out window to reveal what coping mechanisms the patient has chosen. So it might be listening to music, gardening, as we've already mentioned, which is very popular on the ward at the moment, or therapeutic colouring. Obviously, with it being so creative, they are able to share that and get involved with that, and hopefully reduce some of the distress and anxiety that they've had around COVID.
So one of the other groups that I mentioned before was the fortune tellers. They're also called chat boxes as well. So this again was quite an easy group to carry out on the ward. So there are templates online, and we do have templates that we can send out as well. But it is just a piece of paper, it's a folding exercise, and you'll end up with a sort of device that you're able to move around. The patients will put colours on them. We'll work through that. When they open it up, there'll be numbers inside, and then they work through the numbers, and then when they open the flaps, there'll be different coping skills that are relevant to them. But there are also coping skills that they're able to do if they're isolated in their bedroom, if they're on the ward, or post-discharge when they go home. So like Lily said, it will be quite simple things, so watching TV, listening to music, having a bath and those sort of things. And it's quite an interactive way, and we do find that a lot of the patients, they like arts and crafts, so making things that they feel proud of would make them more willing to go back to that and have a look at that when they are feeling distressed. So obviously when we were carrying out the groups, we also needed to follow government guidelines and make sure that we made adaptations to be in line with those, which Lily will speak about now.
Yes, so normally we would carry out our groups in the therapy room on the ward. Obviously, taking into consideration the guidelines of social distancing, we did need to make changes to that. So we've now been carrying out our groups in the lounge or in the garden, as these are wider spaces and we can continue to do our groups. So things like the laughing yoga, we've been able to do that in the garden, and our patients have still been able to enjoy that group and partake in that. Another adaptation that we've made is, like I mentioned earlier, encouraging all our patients to wash their hands before and after groups. And obviously we ourselves lead as role models in doing that. Something else that we've considered is the isolation packs. So we've made isolation packs for the new admissions. As Lauren mentioned earlier, new admissions now are having to self-isolate in their bedrooms until we're having to wait for the swab results to come back. So we're wanting to make sure that we are still considering their emotions and how they're feeling. So the isolation packs are hopefully doing that, and they include activities that they can do in their bedrooms whilst doing this, and they also include the group activities that can be done as a one-to-one. These also we have the templates for this, so anybody that would like to use these, we're able to send those out to you. So these are all the adaptations that we've made and everything that we've considered to hopefully reduce restrictive practices during this time. Thank you all for listening, and we will be around for questions afterwards.
Brilliant. Thank you to Lauren and Lily for sharing there. I can recommend following anyone from Keats Ward on Twitter. They're often sharing their work daily, or their new ideas that they're introducing. So do give them a follow on Twitter. So next we have Danielle and Beth from Mersey. And would also like to say a huge thank you to Leanne Franks, who's been supporting in preparing today, particularly with technology. So big thanks to Leanne there. But yes, I'll hand over to Danielle and Beth, who'll be sharing about how they've been communicating with everyone on the ward.
Okay, so you can hear us. My name's Beth, I'm a speech and language therapist.
I'm Danielle, I'm one of the staff nurses on the MSU service.
And we're here to talk to you about how we've communicated with families and carers, with service users and with staff, and the importance of that really to prevent the rise of the use of restrictive practice during the pandemic. So we're from Mersey Whalley, and we offer secure service for people with learning disabilities. We have a medium secure service, a low secure service, and a step down service. So what we've done with this presentation is we've tried to combine really the whole hospital's response on this subject. So we've tried to ensure that every discipline is represented, and so it's not just Danielle and mine's work, unfortunately, that we're going to be talking about today. But Danielle's going to start with talking to us about how we've communicated with family and carers.
So communication for our service users is very much valued across the whole site. So us as a service, we were obviously quite worried about the effects that not being able to physically visit would have on our service users. So we started to sort of adapt very, very quickly to how we could still get the value of the family visits without actually physically being able to see them. So we come up with a number of things. As a service, we do send out a carer and family letters every so often, which we've been sending out a bit more regularly during this period to update the families. We've also created very, very quickly, we adapted to using Skype to have the visits with the family members, which has been very valued, which IT and the social workers, everybody across site has been brilliant at getting this up and running in quite a short space of time. We also give our service users an opportunity to create a postcard, and we would send them off to the families. One in particular, it was one of our female service users' mum's birthday. So she come up with the idea with the staff to create a TikTok video, which chose the music, she chose the dance she wanted to do, and it was sent off to our mum for our birthday, which she was really, really grateful about, and she said it made her birthday. Unfortunately, that service user's mum's now died since then, so it was a case of it was a brilliant thing to do, and that service user's now got that memories that she's done it. That's that bit. So these are just some of the letters that we have sent out. We can adapt these if needed for families, depending on obviously personal circumstances of them. So we've asked really for feedback from our families across site, and it has been very, very positive. The idea of using Skype sometimes has taken the pressure and the anxiety off family members from not actually being able to physically come and visit, and it's also helped us as staff communicate with them, because we've obviously had a lot of changes going on. We're now in a uniform where we never were before, so it's been helpful for them to actually physically see some of the changes. rather than just us ringing and telling them. So yeah, what we have found is that this has massively helped to decrease the anxiety that was obviously happening like every other service, I'm guessing. Family members value quite a lot being able to speak to the family member's case manager or the ward manager. So it has helped, and as I explained, it has helped us show what we meant by uniform, because when people think of nurses in uniform, it is generally the general hospital in scrubs. So we were able to show it to the family members who wanted it. So yeah.
Okay, so moving on to how we've communicated with service users. What we found early on in the pandemic really is that there was an awful lot of confusion, worry, distress about what it meant for our service users, and a lot of misunderstanding about why things were having to change in the hospital. So of course we've had to have changes to service users, community leave, to family visiting, to their access to therapies and activity. So there's an awful lot for people to process, and there was concern at that time that could potentially lead to increase in incidents of violence and aggression, which could then lead to increased restrictive practice. So we were really keen to tackle this. So what did we do? We've produced an awful lot of accessible information or easy read information to support service users to understand and retain all the advice around things like social distancing, hand washing, personal protective equipment, why things are changing to their routine. And we've made sure that they're displayed on all of the ward areas. The nurses have done a fantastic job in making sure that all of that information is discussed during community meetings, and there's an opportunity for service users to ask questions about that. I think we've really seen the value in developing easy read information, not only for service users but for staff, to make sure that we can all give a consistent message about this, because that helps to reduce confusion and anxiety when everybody is singing from the same hymn sheet as you were. And you know, we're all giving consistent messages around why things need to change and the importance of it. I've got some examples on next slides, so I'll show you them. Another thing that we did, I don't know whether Danielle, you want to talk about this actually? I don't know if you
So this was something that went round on all the social media sites, where it is the salt and pepper experiment, sorry, and it was very helpful in showing our service users, because sometimes the terminology that we've had to communicate with is brand new. We're still adapting to it, so it's been nice to have that physical experiment that we can actually show them, and they've taken great pride, some of them, in showing their family members.
It just shows the importance of hand washing, doesn't it, and hand hygiene. Yeah. Another thing we've done is that we've maintained contact with our service users as much as possible via letterphone, telephone, video calls. So particularly for therapy staff and medical staff, we're not able to go onto the wards as much as we would like to, in order to protect them as much as possible and reduce footfall. So we've made sure that people have been sent letters, information about how we can still contact them if they'd like us to do that, and just to let them know that we're still here really, and that we're still around, and we wish we could be working with them directly if we were able to at the moment. Another thing that we've done is, I think across all the therapies, so psychology, OT and speech and language therapy, we've produced activity and resource packs to make sure that all the work that we were doing in those activity and therapy sessions continue on the ward, and the nursing staff have the resources there to be able to support people with that. And we've also been updating care plans and PBS plans proactively, in cases where we think perhaps a service user might struggle. For example, if they were to contract COVID-19, we've been thinking about how we can produce bespoke, person-centred plans, particular bespoke easy read information to support them with that if it were to happen. So making sure we're planning in advance where we need to. We've also produced guidance and resources for staff about how best to communicate with people when you're wearing PPE. So Danielle's got a uniform on, but if she were on the ward, she'd also be wearing a surgical mask, and the impact of having half your face covered on your communication with people is really significant. So we've produced guidance about best practice of communicating with people when you do have your face covered, and again I'll show an example of that in the next slide. Service users have also been supported to contribute to their ward rounds. So ward rounds aren't able to happen as they usually would at the minute, due to social distancing, but people are able to telephone or video call into the ward round if they want to do that, to make sure that they are very much involved in their treatment and care. And finally, this is just a point about kind of all the non-verbal and all the stuff that happens without talking. So as part of my role as a speech and language therapist, I'm actually based on Danielle's ward a couple of days a week in a blended role, doing a bit of support work, a bit of speech therapy. So I'm just able to be there and sit with people and, let them know that we're there for them and that they can ask any questions, or I can provide reassurance as and when's needed. So all of that kind of ad hoc in the moment stuff's really important as well. So here are just some examples of some of the accessible information that we've produced. So we've got one on social distancing, changes to the therapy and activity sessions, and one about staff uniforms and PPE. We're really lucky to have access to a symbol software called Widget to communicate in print. So we use that to be able to adapt information in a way that is more accessible for people who have a learning disability and might need a bit of support with their literacy skills. So there's always a visual cue alongside the main points to support people with that where needed. Here's an example of some of the letters that we've sent out to service users to let them know about why changes have been to their sessions, and to let them know that we're still available if they want to speak to us on telephone or video call. This is an example of a poster we developed for staff to give top tips about how best to communicate with people when you've got a mask on, because that can be challenging. And this last thing is something that we developed. It's designed to be on the end of a lanyard. I don't know if you can see, I've got mine on here. And it's about it's a tool really to support people to express how they're feeling when you've got a mask on. Obviously, it's very difficult to interpret people's non-verbal communication and their facial expression, and we were worried that there was potentially going to be situations of communication breakdown and misinterpretation. So this is to help with that. Lastly, we've got some examples of the resources that we've developed to help structure people's day. So this was something that our occupational therapists developed around planning your day, the importance of routine, things that you can do even though people may be largely confined to their ward areas and aren't able to go about their normal activities. And this is another resource that we developed in speech and language therapy about communication book, really communication games and communication activities that we can do to make sure that people are socially interacting with one another as much as possible, even though we are physically distancing from each other. Okey-dokey. So we've received some really positive feedback from service users about how we've helped them to understand the changes. So one service user said that they've been given easy read information about why they can't go on trips, and they're okay with that now because they understand the importance of it and why it can't happen. Another person said that they don't mind not being able to go out because, again, they understand why. I think initially there was some scepticism, wasn't there, with our service users about it felt very detached, didn't feel like it was necessarily true, or that they didn't fully understand everything that was going on. But I think all the things that we've done to support that have really helped people understand and be more accepting of the guidance. And the main learning, we know that there was an awful lot of anxiety and distress about COVID-19, and we wanted to avoid that by ensuring that people were supported to understand why we had to make these changes to their routine in the hospital and why they're really important. And we know that anxiety and distress can lead to behaviours that we might find challenging at times, and that could result in increased restrictive practice. But by being proactive and ensuring that people have information in a way that is accessible for them, we're helping to avoid those situations from becoming problematic. Okay, And finally, Danielle, do you want to talk to us about how we've communicated with staff?
So obviously, if we're communicating with service users, staff need to be aware of all the changes. And we were at the beginning of the pandemic seeing that when we were having community meetings with our service users, we could go into that having what we thought was correct advice, and by the end of that hour, it has completely changed. So not only are obviously staff getting a little bit anxious around it, but then obviously that's going to relate to the service users. So we set up a few things that we tried to work out if it would help at the beginning of the pandemic. So we have in every nurse's station, we have a corner that is set up for COVID, so all the information gets printed out on there. If we have, say, an agency staff or a bank staff that comes on that hasn't been there in a while, when they are given their set of keys at reception, they're also given a piece of paper that is to give to the nurses to remind them to ask us what up-to-date information that we are given. Senior leaders have been seen on the ward more frequently. As Beth explained before, we are seeing a lot of the different professions coming on to support on the ward, which has been brilliant. What's the next one? So we have a dedicated COVID-19 page on our staff intranet. We do try to get staff to look at it daily, but if, say, it was a busy day, someone would look at it and then we'd relay that all to the staff members. Staff are being sent quite a lot of information of how to look after themselves. Obviously around the anxiety of coming to work, they've also got anxiety at home about family members, which obviously is going to affect people. So as a trust, we set up all the information and we made it quite easy to get to, whether they're in work or whether they're not in work. I think we've got that later on. So there is going to be Skype calls, quite a lot with the chief executives and obviously our senior managers, because as a trust, our site is away from the main trust site. So it's been really helpful, obviously, with meetings not going ahead as planned. So we've been able to access them. So we have created quite a lot of staff rest spaces. Quite a lot of them are put into place that there's no COVID allowed, and we don't talk about it. We just go in there really if we're feeling a little bit stressed and we just need a little bit of chill out time and try not to think about it really. So we are reviewing all the blanket restrictions. We don't tend to have a lot of blanket restrictions anymore. Everybody is obviously person-centred. But things such as no leave off the ward in community, we are obviously having to review that within ward rounds with staff, and we have a reducing restrictive practice meeting once every month. So we now have, we've sort of relaxed the social media side of the trust, and they set up a Facebook group where obviously staff have to answer a few questions before they can join it, but they have been updating that quite regularly with all the up-to-date information, and it's just been helpful because you can sit at home and think, I need to ring someone, and the number is there for you just to grab. Okay, do you want to talk about this?
Yeah. So we found that being able to have access to information about COVID-19 in lots of different ways has been really important, and whether it's through things like social media or the internet or printed out hard copies, it's been really valuable. And at times, like Danielle said, advice has changed very quickly and often, and it's allowed us to respond to that quickly to ensure we're following best practice. And so we can also keep our service users and family and carers updated with what those most recent changes are as well. So as a trust, we've set up a COVID-19 centre with a senior nurse who you can contact if you're self-isolating. And I think as members of staff, I've definitely felt supported to know the most recent information and how to communicate that with the people that we're caring for as well and their families. So we've got some quotes here. So there's a weekly briefing that's sent out and kept in EMDT stations, as Danielle said, and the trust has sent out all the information that staff need to know. So what was the main learning? So while information has been changing rapidly, we found that weekly emails have been effective. There's been understanding towards staff members whose needs might have changed as well, and there's definitely been increased compassion and understanding around that for people who are self-isolating or people who are shielding because they're high risk. And like we said before, I think we have felt well supported by everything that people have been doing. So finally, we were just thinking about next steps and what we can to continue to learn from. So one thing that I'm trying to lead on is exploring how we source face masks which have a clear window in the front. If you've not seen them, they look a little bit unusual, but they're for people who rely on lip reading. So we do have a number of service users who have a hearing impairment who do really struggle if they can't see people's faces clearly. So that's an ongoing issue. We did look at a few different examples, but it's very difficult to ensure that they meet PPE guidance, unfortunately, so that's something that we're still working towards achieving. One thing that we are also introducing is a co-produced positive newsletter where service users can write articles or share photos about good things that have been happening. One of the things that we're not able to do at the minute is run our News and Views group, which is a service user-led magazine. So this is an alternative to that, where people can send things in to us and we'll coordinate it and share that with all the wards. Just a bit of positivity, really. We've been trying to implement more video conferencing for use for teletherapy and to support service users to access family visits as well, because we've seen the importance of that, really. And we want to make sure that we keep some of the new ways of working, so things like Skype. There's definitely value in that, and we've learned that it's good to have that flexibility in approach and think about things a little bit differently. And I know teletherapy and use of video conferencing is something that's definitely some of the service users I've worked with have really valued. So that's something that we want to keep post COVID-19. I think that's everything from us.
Yeah,
Danielle,
that's everything.
Thank you very much for listening.
Thank you.
We are going to take questions at the end.
Brilliant, thank you. Obviously, you did a huge amount of work there. So it's great to hear about everything that you've been doing with the whole ward community, patients and staff. And it also leads quite nicely as well into Steve's presentation next, with the mentions about staff wellbeing and spaces where there's no talk about COVID and things like that. So with that, I'll hand over to Steve, who's the Associate Director for Leadership at East and North Hertfordshire NHS Trust. So,
thank you. Thank you very much, and thank you to my colleagues for the two previous presentations. Some great work going on. Really, I just want to tell you a story, really. I'm the Associate Director for Leadership at East and North Herts. I'm a children's cancer nurse by background, and my main responsibility here at the hospital has been the development of leadership and management skills. And about the beginning of February, I was sat with a colleague from our quality improvement team, and we were having a cup of coffee, and basically we came to the conclusion that our diaries were meaningless, that we could well see what was going to happen with coronavirus, COVID-19, and all the things that we had in our diary were just about to get ripped out and put on pause or hold. So rather than wait for that to happen, we decided that we would start to think about what our new roles would be. And we decided very clearly that our new role would be to guide our 6,000 members of staff through the COVID-19 process and keep them as well and healthy as possible. So first thing we did was try and see who else we could co-opt into our newly formed team, which we decided to call, for an odd series of reasons, the How Are You Doing team. At this time, other things were starting to be cancelled, and some of our outpatients clinics were starting to be shut down as the hospital reconfigured itself, waiting for the COVID onrush. So some of the clinics that we noticed were being closed down straight away released some clinical psychologists. And so we quickly nabbed them to join our emerging team. So with some leadership facilitators, coaches, some therapists, some quality improvement coaches, and some clinical psychologists, all with their normal work to do, and with this How Are You Doing work on board, we set off on our journey. We started to look at best practice. So what was the evidence out there about how you guide a large number of people through a sustained period of stress and anxiety? And I'd been very lucky in my previous work at another hospital that I'd had contact with the Army, and I knew several of the psychologists in the British Army. So I called one of them up, and really interesting, their story was powerful. I have been in the NHS for 30 years and have met many crises and major incidents, whether it be bombs going off in London when I was based in London, or the cyber attack of a couple of years ago. Our normal response to these kind of crisis points is to charge at them, throw every resource we've got at them, and within a day, 2 days, 3 days, the crisis is over. We tend to breathe a sigh of relief, and then someone somewhere says we should have a debrief, we should think about lessons learned, etc. But this wasn't going to be that kind of crisis. It wasn't going to be 3 days. It was going to be long and sustained. So my question to the psychologist from the Army is, how do you prepare people for such sustained periods of stress and anxiety? And really interesting, his almost immediate answer was a healthy rhythm, to establish healthy rhythms on a day-to-day basis. And that was healthy rhythms from their leaders and healthy rhythms within their teams. So we had a bigger conversation and we explored some of the things that they use. We also then started to do some research and some digging into best practice from other sectors and areas. And we started to form a series of tools, models and ideas. So as the group is starting to form, our thought about what we were going to do to help people started to take shape as well. And we decided we were going to work in partnership with our health and wellbeing team and to see what best we could then offer. So the first thing we started to do was think about information, and it's been picked up by several of the people already, how we were going to get information to staff. So we immediately just took over some space in the hospital and created the How Are You Doing Hub. In the How Are You Doing Hub, we started to put every single piece of information that we were starting to gather. It became an open and transparent and access 24 hours, 7 days a week space where information started to arrive. What we noticed almost instantly as we were putting information out there, people started to offer questions there as well. So if we left it unmanned for a period of time, we'd come back and there were bits of paper, post-its with questions. So already this was becoming a central point of interaction with the organisation. We then started to put out more information, options, and as we started to uncover the options of support that were being available, we started to share them as well. So very quickly, websites like Headspace, Silver Cloud, Daylight, Sleepio, iConnect, all these kind of services were coming online well before they were going to be launched by the NHS. Free access if you have an nhs.net email address. So we started to put those things out. So we started now, first of all, with some physical spaces and some information and online self-help support processes. The spaces bit continued really, really quickly. And very, very early on, we realised that some of our staff on ITU in some of our theatre areas, which had been turned into mini ITU spaces, these people were not going to get away from their clinical areas. And so we moved some of the spaces to them and we created some things called wobble rooms. And I'm sure many of you have seen the ideas on social media about wobble rooms, just these safe places to go, no talk about COVID, just for 5 minutes of respite, just from the onslaught of wearing PPE all day or dealing with the pressures that were mounting. So we're now starting to get into this position of we're starting to see spaces become important, information and self-help. But after some self-help, there were some people starting to emerge and some groups who needed a bit more of an intervention. And it wasn't a great big intervention of formal debriefs or clinical psychology sessions, but it was something about the leadership that they required on a day-to-day basis on their wards. So we took then some of the work that we'd worked out from the British Psychological Society, who sent out a really helpful paper early on, and our colleagues from the Army. And that's when we developed our first tool. We developed several tools, but this was our first. And I think the next slide is the 5 questions. So the 5 questions. This has become incredibly popular in the organisation, and several other hospitals have now picked up on these 5 questions. They seem quite harmless in your first asking, but they are based on both the work of the King's Fund on compassionate leadership and the paper that we mentioned earlier from the British Psychological Society. So this was to represent what our army psychologists had told us about a healthy rhythm, a daily healthy rhythm that checks in on your people, that tries to reduce stress and anxiety each and every day to stop the harmful accumulation of stress over time. So the first question in these 5 questions of a healthy leadership rhythm is, how are you doing? Now, most times when you ask the question, how are you doing, to a friend, colleague or a team, your likely response is going to be, I'm fine, thanks. It's almost a standard greeting and a standard response. And we were really comfortable with that. Occasionally you'd get, how are you doing? I'm fine, thanks. How are you doing? Or we'd get people who would actually honestly tell you what was going on for them. But it was really important to skip quickly to that second question, how is your team doing? This created some safety. This created some psychological safety for the people we were working with, because the question does 2 things. First of all, it mentions the word team. And now all of a sudden the individual you're working with is aware that they're not in this on their own. They're part of a team. The question is, how are your team doing? I'm a member of a team. And that was a really important connection for us. But it also allows people then to give you the answer in the third party. They don't then have to say anything about themselves. They might be nervous, anxious. There is a bravado, especially in some of our ED, ITU colleagues, that actually to admit that I'm struggling, feeling overwhelmed, stressed, it isn't acceptable in my role. So asking this second question allowed them to use third party. So yes, I'm fine, but my colleagues are struggling with. There's some members of the team who are stressed at this moment. People are frightened by what might happen. So using that third party language really helped us find out exactly what was going on in the experience of our teams. The third question about colleagues was our interdisciplinary connection. We wanted people now to be thinking about, for our nursing staff, to be thinking about how the doctors might be coping, for our doctors, how our pharmacists might be coping, for our pharmacists, how our wide range of therapists might be coping under the present condition. And again, the essence here is about creating this bigger team. We're one organisation, one team. We're not going to get to the end of this unless we do it together. The fourth question now is when action starts to emerge. So almost what you want to be saying here is, great, I'm pleased that you've told me about how you are. Thank you for sharing some stuff about your team and your colleagues, but what are you going to do to help them? And the reason this is really important is one of the reasons anxiety starts to climb is we've lost control. We have no control now over the future. I have no idea when my kids are going back to school. I don't know if I'm going on that holiday I've booked to Spain, and from a day-to-day, I think, as one of the other speakers mentioned, the rules seem to be changing, the advice is changing, so there's a loss of control. This starts to put some control back for people. So you've told me about your team, you've told me about your colleagues. What can you do? What can you take control of to help and support them? When they're busy, when they've got things to do, and when people feel they're being helpful, that reduces stress and anxiety. When people are kind to other people, they're feeling good about themselves. And therefore, then that final question is, brilliant, I'm glad you're helping your team and your colleagues in that particular way. What can I do to help you? Here, the team leader, etc., is starting to say, I've listened to you, I've got your back, how can I help? We found that these 5 questions are now appearing all over the hospital. It's become our little healthy leadership rhythm, which happens almost throughout the day. Little check-ins that says, how are things going? I am listening to you. Your voice has value and I want to hear what's going on. So as well as the 5 questions, which as I said, have now become popular in several other hospitals as well, we started to put out some other products. T-shirts, as I'm wearing now. So we started to grow our How Are You Doing faculty. We started to grow some more spaces. We linked in with the charity people and they started to refresh our staff rest areas. We started to look at communicating tools. So what's the difference between communicating in normal times and communicating in a crisis? How do we help people communicate in a crisis? We then started to do some mental health first aid, helping our team leaders look at what are the signs and symptoms I should be looking out for in my colleagues to know when they're struggling and what the first steps I should take to help. We also then started to think about our colleagues who might be at home, either isolated, working from home, etc. We think at one point we had over 1,000 people at home, whether isolation or working from home. How do we offer them support? So we started to, again, put some guidelines together to help them. So we started to put all these tools together, initiatives together. We launched things on a week-by-week basis so people would look forward to the latest thing. Our final thing that we launched last week to sort of wrap up some of the work we were doing as our activity in terms of COVID has started to reduce and we're starting to get back to some sort of new normal was with it being Mental Health Awareness Week last week and the theme being kindness, we launched our Pay It Forward initiative. So last week, Pay It Forward was everywhere and people were paying forward acts of kindness around the organisation. One of the other things that we did do and we evaluated simply last week was I personally stood at the front of the hospital between 7 o'clock and 9 o'clock each day for 61 consecutive days. And the only thing I did was I asked those people that were coming on duty to have the best day they possibly could. And I thanked all the people that were leaving from night duty for all the work they put in. What that produced was really, really impressive. I used to get tips from people of where I should go that particular day. So people would come up to me and say, Steve, they're struggling on Ward 10. Steve, such a thing is going on in ITU. So almost simply being that visible leaders. And again, I think one of the other speakers mentioned visible leadership. Simply being visible, people would come up to me and direct my day, really. They'd control the agenda of my day and really direct where I was going. On one particular day, we decided to do one of those stopwatch counts of people as they came in, and we decided to count how many smiles we got on a particular day. And on this particular day, we got over 300 smiles from our interactions as people were entering. So we think that that initiative alone launched over 20,000 smiles into the organisation. And again, we feel that is quite a positive interaction. So with all the tools that we've put in place, the spaces, we put some coaching ideas together. We would walk the areas early in the morning. We would then set up some one-to-one support, some debriefs, some group support sessions, and some online sessions where social distancing meant we couldn't get the group together. We're looking now at evaluating some of that work, and our early signs are really quite encouraging. Some of the tangible efforts are about reduced sickness. Some of the other impact we think that we're starting to see in the evaluation is that people felt confident to go and work in areas that were not their normal areas. People who were moving from non-COVID areas to COVID positive areas where patient care was being delivered. People stayed in the hospital even when their initial desire was to leave because of the support they were being offered. So we're going to evaluate the work now. We're going to pass on most of this now as we start to calm down a little bit to our health and wellbeing team here in the hospital and hope that we don't have to pick up in the intensity that we've been for the last 3 months with a second wave later on in the autumn. I've kept that a little bit shorter than I thought because time was just starting to run away with us. Thank you very much for listening, and I'm looking forward to any questions.
So thank you so much, Steve. Thank you, Lauren, Lily, Danielle and Beth for all of your excellent presentations. Just before we move on to the question and answer session, we can see that for some of you, some of the slides were cut off and you weren't able to see the full screen. So we will put those onto our website at some point following today's webinar. Thank you also to everyone that has submitted questions. Unfortunately, we don't have time for all of them, but we will try and get through as many as we can. So the first question might be most appropriate for Danielle and Beth. We've had a question about have you had any access to easy read materials about COVID-19? And if so, where did you get those from?
So we've produced an awful lot of easy read information in-house ourselves using the symbol software that we have access to here, Communicate in Print. There's an awful lot of easy read information that is just widely available out there. If you have a Google search, there's lots of things. Twitter's also a brilliant source of information. There's lots of things that are being shared on there from lots of different trusts. I'd encourage people just to have a look at what's already out there. we may be able to share some of the information that we've produced, but it is quite specific and bespoke to our service. So depending on what type of service you work in, or what information you're specifically looking for, my first point of call would be always have a search on the internet and see if there's anything out there that's widely available.
Brilliant, thank you both. Another question that we have had through is, have any of the teams had any issues with patients having to isolate in their rooms whilst they're waiting for swab results, or if anyone has refused to isolate, and how you've been responding to that? So maybe if we go to Lauren and Lily first, I don't know if you have any thoughts about that question.
We've been quite lucky, no one's actually refused to have a swab, but we do find that when people are coming in, obviously it can be quite daunting for them, particularly if they've not been in a hospital setting before. So just to touch on again what we had said about the isolation pact, was just making sure that they were still occupied in the room, they've still had access to that one-to-one support, and then following on from that, when they were able to come out of the rooms, just making sure that then they were orientated around and shown around as well.
Brilliant, thank you. And Danielle and Beth, I don't know if you had any other thoughts you wanted to add to that.
Yeah, so we've had a few cases of COVID across the site. What we found, especially with our service users, is that when we're explaining things to them, it might be terminology that they're not used to. We had a new admission this week, and when we asked him if we could do the swab, he didn't understand what we were asking him, so we had to physically do it on a staff member and show him what we actually meant, and that's how he realised what we were going to do, and that's how we got round his understanding of it, really. In terms of the isolating, we haven't really had any issues with anyone who actually has needed to isolate. I think they've all been very, very understanding. We unfortunately had one case in a flat of 8, which meant the whole flat would then have to isolate. But we were really lucky and they were very understanding about it.
I think when we've had cases where we suspect people might struggle more than perhaps other people in the hospital, we've come up with proactive plans, proactive, bespoke, accessible information about what exactly will happen, what would they expect, what the expectations are. And our occupational therapists have also been coming up with isolation plans for people, so taking into consideration what their interests are and coming up with a plan of activity to keep them occupied and engaged if they do need to isolate.
Brilliant, thank you. That is really useful. And we've probably got time for one more question. So we have one other question in the chat, which was about body-worn cameras, which isn't actually something that's included in our change package, but we had one viewer asking about whether using body-worn cameras is something any of the teams have considered using, and if not, why not? I wondered if, coming from a forensic setting, I don't know, Ammar, if you have any experience with this.
Well, I know that several units across the country have been testing body-worn cameras for about the last year or year and a half. And I've seen some sort of mixed evidence and results from those tests. They seem to work in certain circumstances, but not always in others. We haven't been using them in our organisation. I think the key really is to think about what is the purpose of that really, and how does it add or augment to the relationship we have with between our staff and service users on a ward. Because ultimately what all of our speakers today have described is ways of sort of working together collaboratively and finding ways to sort of break down silos of information or of power, and to be more appreciative of each other. And I think potentially body-worn cameras can actually reinforce power hierarchy on a ward, and for people to potentially be reinforced around their paranoid fears. So I don't know how useful they really would be, but I guess it's for each organisation to think about how they might test it if they were interested.
Brilliant, thanks, Ammar. So I've just seen the time, so that's probably unfortunately all the time we've got for questions for now. But thank you again to the teams for answering those. And I'm going to hand back over to Amar now for final reflections and close.
Thank you, Matt. Thank you, Emily. And thank you to all of our speakers for being brave enough to share your work with us today. We've learned quite a lot. There's been some fantastic ideas shared, and that is the nature of quality improvement, that you have freedom to sort of come up with ideas together as a community and try them out and see what works and what doesn't, and then share them. So I know that many of the ideas you've shared today will be taken up and tested in lots of other units around the country, and that's amazing to see. So thank you all for joining today. We'd love to host more of these sorts of webinars if people find them helpful, so do let us know. And thank you once again. Speak to you all soon.